your symptom management, by the way that you care for them. Every day that's what you do, but every day that chips away a little bit at you as a person because you have to give. And so the question about this addressing suffering, you have to acknowledge it. You need the courage to ask the question of yourself, can I do this today? Am I able for this? And one of the things I often try to teach when I do the courses with the students is you have to have the strength to stay and hear the answer, because it's really easy to deliver the bad news. I can teach you that, but can I stay and hear if you fall apart when I do that? So that's the skill you have to teach people in compassionate care, is to stay and hear the answer. So why is it important for palliative care? Well, you heard this yesterday in the plenary about this idea of pallium. To cloak and cover, it doesn't mean to hide. It means to provide a support system, a support network. And for practitioners, for clinicians, and I'm using nursing, this is in my experience for nurses, is that if you understand what compassion means, it helps you understand why suffering occurs. It helps you have the conversations around difficult questions. It helps you to hear the relational voice of others, so that when people have to make complex or difficult decisions, you're hearing the voices from different levels, from the family, from the friends, from the people who care, from the other clinicians. But finally, a compassionate response is one that respects our boundaries, where we find that we can't do more or we need to be clear about what it is that we can do. In the United Kingdom, following some difficulties they had there, they wrote this document called One Chance to Get It Right. And I think that's absolutely true. Generally, we only have one chance with every patient, so we have to get it right first time. We don't have to be perfect. Nobody's asking us to be Superman, but we do have to work to try to get it right. So a colleague of mine, Michael Carney, he's a and Balfour Mount, of course, many of you will know, they wrote many articles around this issue of self-care for physicians. And I think if I take this and look at it from a nursing perspective, it's quite interesting. So basically, there's three things that he said that we as clinicians in palliative care do. The first is that it's our knowledge and our competency that help us facilitate people to let go. And that may be something that's quite important as nurses, that we are very conscious that we have to help people let go of this life because of what their illness is doing. The second element is it's about the quality of care we offer. Now, I don't mean documents that tell us about quality, but it's the little things that we do every day that make the difference. It's not necessarily that we have to change the world, but a very small compassionate action can change the world for the patient and the family. And the final point I think is very important, particularly for nurses, is that you are the most potent medicine that you give to your patients. The fact that you come in every day, that you are present to them, that you are with them, makes the difference. Even when the greatest challenge we have teaching communication skills is people want to know what to say. Michael Carney wrote a very good paper that said, it's not what we say, it's how we respond. And the response is simply by having the courage to go back into a difficult, complex situation. And nurses have to do that every day. Of course, I'm not denying that's an issue for other clinicians. They do as well. But nurses, you are constantly there in the midst of what may be turmoil, and you're trying to sift and sort a little bit to see how that can be helped in a different way. Of course, we know Cecily Saunders was a nurse. What did she teach us as a nurse and as a doctor and as a social worker? Well, in many ways, the presence of another person as an aisle of security, that is a critical element for us. When I stand at the door, you know, I did a fellowship in Dana-Farber in Boston, and I would follow one of the doctors, and she'd go to the door and she'd automatically stop at the door for a second before she crossed in. And she didn't know she was doing it. I was observing her. And then she realized she needed just a moment of reflection before she stepped across the threshold, because she knew when she went in there, that person needed her for security. So remember that you bring a security to the patient when you arrive. It's changed. When I was a student, I trained in London. Nurses used to appear like some fearsome creature. because they would have some hat on their head made of lace with a thing under their chin, and they wore these fearsome aprons, and they had more badges than a third world general, and your badges were that was it. If you had a badge, you were in charge, okay, and power. And the drugs trolley that you must have pushed around was a weapon of war, because you'd be shouting across at the patient behind you, have you got your bowels open? You know, and the whole ward would hear these things. That's changed, thanks be to God, that's changed. But actually there was something, there's a security in that. People need to feel secure. And by showing security, you help with that compassion itself. So in a way, we have a responsibility to learn the language of compassion. And the reason I say that is that you may be the first person that actually talks about death. Because depending on where they've come from, nobody might have mentioned that possibility or that likelihood. So how do you talk about death compassionately? One thing I teach my students to try and do is to have a compassionate conversation with a member of the public about explaining the process of death. Not the Hollywood deaths that you see on the television, but the reality of what death means. And it's really hard, because we can talk about chain-stroke breathing and we can give all sorts of medicalized terminology. But if you're speaking to someone's grandmother or someone's husband and they say, what will happen when she dies? How do you explain it in lay terms? And that's a compassionate skill. So how do we foster compassionate self-care? Well, as I said, in order to have compassion for others, you need to have compassion for yourself. I think one of the things I try to say is, you know, when people come for a job, I'm really not interested in your CV. I mean, I can read that. You've done a beautiful job, it looks amazing. And, you know, if people come to me and say, it's my life's ambition to work in palliative care, bye, because it's nobody's life ambition. It might be a career ambition, but you have to sort of decide where people are going. But what I want to know is, who are you? What is it in the fullness of your life that makes you you? Is it your family? Do you like to go in the mountains? Do you like to ski? Very Swiss thing. Do you like to ski? Do you like baking? Do you like dancing? What is it that makes you you? Because if you can identify what it is that makes you you, then that will help you in the difficult times when it's hard to be a compassionate practitioner. Because you need to remember that you are also someone's husband or someone's wife or someone's partner, and they will need you. And so you need, that self-care comes very much from saying, I need this. I need this for me, and I have a right to ask for that. Now, you can take that in a different way. How do we manage our compassionate organizations? Because nurses will say, oh, that's fine, I can do it for me, but my organization doesn't care. They're not necessarily compassionate towards me. So a lot of the compassionate community stuff really pushes, and I know in Canada you have the Compassionate Workplace program. That really is important to try to get organizations to realize, and particularly for nurses who are their largest workforce, that they really do need a compassionate response to manage those difficult situations. So how do you do that? Well, I think a key question that you can reflect on: what brings me to this work? What sustains me in this work? What is it that keeps me coming back here every day? And if you can answer that question, then you have a good chance of survival in palliative care, a lesson I learned when I was young. Many of you will know Ira Byock, and you'll certainly know this book. And the 4 things that matter most. And nurses particularly are exposed to these conversations. The conversations that you hear between people. Please forgive me. I forgive you. Thank you. I love you. And I always put at the end adieu, because for the French patients that I work with, adieu is a very deep, meaningful word. It's not just goodbye. It's goodbye, I won't see you again. Adieu is a really meaningful word. And in French, they have some beautiful expressive words, which we don't have in English, to talk about our work. Accompagnement. It doesn't mean to accompany, it's something much deeper. Être à l'écoute is a word that doesn't have a meaning in English. We know we can translate it, but it has a deeper meaning. So there's something culturally rich about being able to be part and answer these questions. But think about your presence at those critical conversations. What is my role here in a compassionate way to enable these conversations to happen, to enable healing to happen, to help people find a way through in this difficult, painful time? We talked about the broken pot. I think one of our key skills in palliative care is what I call the reconstruction of lives that can never be the same again. So your job is to put the bits of the pot back together so that someone realizes, I'm Phil Larkin. I'm not just a patient with a label that I'm going to die. I'm a person who has to be seen. But the problem is when you repair a pot that's been one of your beautiful pots, it's never perfect. There'll always be a crack. There'll always be a gap. It's to respect the cracks and the gaps, to help people understand, I can't make it perfect. I can't change the inevitable, but I can do the very best I can to help you at this difficult time. But your job is to put the bits back together, and that can be the most compassionate act that you do. And what is the risk if you have non-self-compassion? So this is an image a colleague of mine in Ireland painted. And if you can see just around the neck of the person is the black dog. So we talk of the black dog of depression. And that can drag people down. And when you see that within your team colleagues, because I always come back to the fact that our compassion needs to extend to all the members of the team, not just towards the patients and families. That can be really difficult. And in my experience, when somebody has left a palliative care team broken because nobody thought to show them compassion, it can be devastating. Because as nurses, it's assumed that you are compassionate. You ask the public and they'll say to you, what do you want when you're for end-of-life care? Somebody who is compassionate. You ask what people want of nurses, they will say a compassionate nurse. They're asking a lot of you. But the difficulty is when you're not feeling compassionate or you've not been able to manage that within your teams, and it's painful and difficult. And that person leaves, you are bereft, and they are at risk. And I've seen that in practice where people have left and their lives literally have been on the line because it feels I am no longer worthy, I can no longer care, which is not true. But just think about that as how do we support each other? So I want to just try to talk about this. So you have to imagine, we use your imagination now. So this is a statue. Imagine it's actually the size of this stage. It's enormous. It's from a garden near my house in Galway in Ireland. And it's made from the leaves of an oak tree. And it tells you an ancient Irish story. So this is the goddess of spring. And her name is Eru, where the Irish name Ireland comes from. And the story says that she is sent at the end of winter to listen for what is going on under the ground. And when she hears the first sound of the flowers coming up in the spring, she tells the world that winter has finished and the spring has begun. Your role as a nurse, particularly in palliative care, is to listen to what's going on underneath. Because often what we see on the surface is not the reality. It's the capacity to use 2 ears and 1 mouth, I think it's Mark Twain that said that, in that proportion, and to stay silent while whatever has to unfold unfolds. So you need to listen for those sounds underneath the ground, and when they emerge, to be there to tend them. We talk about tending the garden, tending the grass. You have to tend them carefully, because things, you know from your practice, things will come up that nobody expected. The marital breakdowns, the history of alcoholism, the drug abuse, or the member of the family that's been estranged for all sorts of reasons. And the tragedy is, in this end-of-life scenario particularly, all of that is thrown out on the table. And it can be devastating for people. So you need, and I use the word listening to the still small voice, because it's a bit, but actually it doesn't come from the Bible, it actually comes from the Talmud. It goes much further, where in fact that the translation from Hebrew is the voice of fragile silence. And that's what you need to listen for, the voice of fragile silence. And by doing that, you exhibit your compassionate self. And so, what can I say? You are the difference you make. That was what Henri Nouwen said. You are the difference you make because every little action that you do has the potential to change the world. And when you spend that time in reflection, thinking of those images I showed you at the beginning, thinking of what it means to be a compassionate practitioner, thinking of the challenges that compassion brings, and remembering that you, as the person that you are and the practitioner that you are, make a difference in every action that you make in your practice. And with that, you can actually then transform the world for every patient and their family. And a final thought, so I go back to Irish language, which I grew up with as a child. And what it means is we live in the shadow of each other. So you cannot, we talk about autonomy and being alone and being a separate person, and that's a very important element. But the thing I think that's really, really important is that we realize that we are dependent on each other. And compassion enables us to be a caring and dependent group. As nurses, we rely on each other. We only can do our work because we have that support. But we live in the shadow of each other, so the shadow is nothing to be afraid of. The shadow is something that can support us. It's a wall and a protection and a cloak. And so, thank you very much for your time. I hope that you will find the depth of compassion in yourself, because it's always there, and with that to help you find compassion in others. Thank you very much indeed.
Okay, thank you so much. We do have time for questions, so David is going to run around with the microphone if anybody has any comments or questions.
Thank you, everyone, for the presentation. My question is about the last presenter. It was a really informative presentation. In the beginning of the afternoon, someone told us compassion cannot be educated or taught, but it can be cultivated. What would you tell us about that? Because how do we cultivate compassion in our future generation of nurses? Thank you.
Okay, well, we'll back up. Okay, that's really, can you actually teach compassion? Well, just to say, there is some work that has questioned whether you can teach it. It's actually done in Boston, at Harvard. So there was a psychiatrist there called Helen Weiss, and she did this study where she looked at first-year medical internees, and so she divided them into two groups. She gave one group compassion training and the other none, and then she sent them out into outpatient clinics, and then she checked with the people who'd received the care to see, did you find the difference? And they did. So it was very clear that some level of training around good communication and good posture, all these things helped. However, my experience is that nurses learn compassion by working alongside a compassionate practitioner. And that's why I think clinical placements, or stage as they say in French, are really important elements for nurses. We need to make sure that our senior nurses understand the importance of their ability to share their competence and their skills, to show that they can use their hands well, to show that they know how to respond to people without necessarily having to have all the answers, and to be able to know when it's appropriate to be present or to withdraw. Because sometimes when you've given your compassionate action is sometimes to do nothing, or to step away, to allow something to filter, to allow something, you know, if it's a really hard situation, but just to be there in a presence. And I find that nurses can find that really difficult, because even though it's 30, 40 years since I trained as a nurse, I noticed that today we see more nurses coming into palliative care from, originally it was from oncology and community nursing. Today I see nurses from intensive care units, and they come with a mindset. It's a very organized mindset. They like things sorted. I'll sort out my symptoms. I'll make sure we've, and that's cool, but it can be a little bit difficult when you're trying to get some of this other stuff in. So my advice is to get some leadership work with the senior nurses to understand their role about compassion. There's a really big project in Tanzania at the moment about bringing compassion into the curriculum for nurses. They've just changed the curriculum in Tanzania to do this. And it's really making a difference. But it's giving knowledge to the students, but it's also making sure that you can get the senior people on board.
So I have maybe a comment and then a question, but just while we wait for other hands. My comment is, Professor Larkin, I'm so happy that you're here because, you know, through any presentation that you ever give, or at least that I've ever heard, or through your writing as well, you're incredibly skilled at reorienting us towards what matters and refocusing on really the crux of what it is that we're all here for, right? Compassion, relationality, those pieces. So just thank you so much. I think this was really lovely. My question is, I'm wondering if we can push a little bit, like the ideas that you've shared here, beyond the level of like the individual interpersonal, and think about the political influences on a nurse's capacity to enact all of the things that you're kind of calling on us to enact. So for example, earlier today in one of our nursing sessions, the session was about kind of engaging with families around palliative care emergencies in the home. And one of the attendees came up to the microphone and said, oh, well, but in my context, like nurses are not allowed to kind of have these kinds of conversations unless the doctor has, you know. And I mean, in our context here in Canada, that's not the case. Nurses do have authority and autonomy to really go there and engage with families and patients, but sometimes they don't because of a perceived limitation on their scope of practice. And, you know, is it really my role to go there? So I'm wondering if we can, because it's not just about individual attitude, right? Like there are social forces that constrain us from really leaning into these moments and to enacting the full potential of our compassion, to tend the way that you're kind of calling us to do. So there's that piece. And then I'm also not totally sure that I'm sold that the public trusts us as much as they say that they do. Yes, it's true that if you survey the public, they will say that we are the most trusted, that they see us as compassionate. But sometimes I wonder, do they really understand what that means, or do they see us as the most friendly? Do they see us as the nicest? But, you know, are they actually fully understanding the full scope and potential of our role to make a meaningful difference at this relational, existential, psychosocial level? Does that make sense?
Yeah, no, absolutely.
Because if they did understand that, then I feel like they would be lobbying the governments much stronger to treat us better. Yeah. So anyway, I don't know. Can we push this to a political level?
Just to talk about the final piece first. I mean, I think that's absolutely right. I think when the public say they want a compassionate nurse when they're dying, they don't really understand what that means. What they do need, they want someone who cares. They want someone who's friendly. That's absolutely right. However, the other thing I would say is, you go to all the big institutes here. I'll give you the example of Dana-Farber, because that's what I remember. That really sparked my interest here. You go in and they have this amazing wall of sponsors. And they will have somewhere in their mission statement, we are a compassionate organization. But you ask them to just demonstrate that and you don't see it, or you may not see it, okay? Because they may be compassionate in some areas, but not in others. And I think the reality is we do need to explain to people, both the public and organizations, what it means to be compassionate, what it means for the nurses or the colleagues to be compassionate, but what was the responsibility at a societal level and an organizational level to be compassionate, because it's got to be a holistic approach. It's not just the individual, as you said. I think that's absolutely right. I think sorry, what was the other bit you asked me about? I've forgotten it on my head.
The first piece was about kind of fully stepping into our scope.
Oh yeah, sure.
Understanding
Okay, so
that
was
actually, you know, there really is no such thing as like a doctor needs to have done anything for us to actually be able to engage with somebody, ask them, what are you most fearful of? What do you hope for?
Yeah.
How can I help you?
Yeah.
No, nobody can take that away from us, but I feel like sometimes we feel constrained in fully meeting that moment because of perceived limits to our scope and our professional autonomy.
Yeah, no, absolutely. I mean, I used to do a talk years ago, which I called Angelus Nursing. So for those of you who are not born in a Catholic tradition or an ancient Catholic tradition like I was, you know, the beginning of the Angelus is, I am the handmaid of the Lord, let it be done to me according to thy will. And many nurse training schools used to adopt that. You were there. When I was a student, they used to have this thing called the blessing of the hands. So before we could actually go anywhere near the post, we had to line up and the priest came and blessed every nurse's hands. It's a nice idea, but it gives an image of we are there to serve others, and particularly to serve the medical profession. Je suis désolé, pas ça, je sais dire ça. But there was, and so we need to change that perspective, and we need to own our practice. We need to own ourselves as practitioners. We have just developed the advanced practice role has just come to Switzerland. It's only in the last few years. In fact, I was in charge of the master's program there when it started. And the problem was, it was like when I was standing up in front of the medical staff and saying, an advanced nurse practitioner is able to prescribe, they're able to do this. I mean, there was shock and horror and like oranges thrown, get off the stage. How dare you say such a thing? Because of the way in which the organization is structured. But I believe that if we have our own strength, and we need to make sure that the young students understand this, you are the difference that you make, and we can support you to find your voice. But it's that you have to do it in different levels, you know? Have you got the organizational support from your directors of nursing and your leadership in nursing to allow nursing to be visible and strong? And it's not about unionization. I mean, that's one another, that's a different thing. But it's about, we also have to have the courage of our convictions. Like, it's really hard sometimes when if I'm there, I'm saying, no, I don't agree with that, you know? For doctors, I often say, you may make the decision and that's fine, but you have a responsibility to make sure I understand why you made that decision, because I'm the one that's going to have to speak to the patient and family when you've all gone off and they're asking me at 3 o'clock in the morning, why did the doctor say that? So I'm not taking away the power from the doctor, but I'm making sure they understand their responsibility to me so that my professional self can actually be fully enacted.
Very nice, thank you.
Cool, thank you. That's great. Oh, sorry, thank you. Please. That's great. No problem. Let's go.
Okay, what a lovely way to close our nursing sessions. Thank you so much, Professor Larkin, for sharing your perspectives and reminding us that compassion is the doing in response to suffering, and the importance of compassion for ourselves, for others, and from others, including the institutions and organizations, to do the important work we're doing. So thank you so much again. Thank you all for joining us. That concludes our time together today. Just a reminder, if you are wanting to claim your accreditation hours, the code for this session is 1737. So thank you very much and enjoy the rest of your day.